Hi, I am the program director for Mama's Voices, Nicole Purnell, and thank you for joining us to watch a replay from one of our AIM Extension webinar series that was hosted in August of 2023. We want to thank the AIM program for their support and trust with the lived experience integration into quality improvement community learning. These materials were developed with support from the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services, HHS, a part of the cooperative agreement with the American College of OBGYNs, under grant number UC4MC28042, Alliance for Innovation on Maternal Health. The contents do not necessarily represent the official views of, nor endorsement by HRSA, HHS, or the U.S. government. For more information, please visit HRSA.gov. And now we'll get back to our webinar.
Let's move on to introductions for today's speakers, which I'm super excited. I have to say, as I was just sharing with the speakers before we started, this has been a field that I've been watching for over 20 years, and am super excited to see what they have to share with us today. This whole issue of risk management, it really arose out of a challenge that many of you all shared with us, which is sometimes we encountered hospitals that are struggling with how to authentically engage patient-family partners on their QI teams because of fear of litigation or because of pushback from risk management executives. And this aversion by risk management, traditional risk management, to involve patients in situations that might trigger their own adverse events, or particularly if there was harm done or errors made. And of course, we know through our experience that involving those with lived experience is actually some of the most powerful healing work that can happen, both for patients and for hospitals. So I'm really excited to hear what our presenters are going to have to share with us today. Dr. Thomas Gallagher comes to us from the University of Washington, where he is a general internist, a professor in the Department of Medicine, where he's also the Associate Chair for Patient Care, Quality, Safety, and Value. He received his medical degree from Harvard, and we will be pasting into chat a little bit more about his bio if you want to read a little bit more about his background. Dr. Leslie Carranza comes to us from the Mayo Clinic. She's the chair of quality in their OBGYN department. She's done and continues to work very actively on improving indicators for monitoring quality of care during pregnancy and childbirth, and particularly patient-reported outcomes. And she received her medical degree from the University of Minnesota. And again, more bio around her will be posted into chat. So with that, I am going to bow out and let Drs. Gallagher and Carranza take over and illuminate us on how we can address harm in the medical setting.
Well, thank you so much. It is wonderful to be here today. I'm a physician, as you heard. I'm a professor of medicine and a professor of bioethics and humanities, and that really has summed up my career, which has focused on this interface between the quality and safety of care and communication and accountability, especially when things have not gone well. I learned early on as a medical student and a resident that when things don't go well in healthcare, as clinicians, we don't know what to say. We oftentimes keep uncomfortable information to ourselves. We're ashamed and embarrassed. And when we do try to talk with the patient and family about what happened, oftentimes it goes poorly and ends up making things just worse. So I've led a research career looking at how we can respond more effectively when something has not gone well in healthcare. And we have expanded that work to create a learning community at the national level of organizations and individuals who are really committed to responding to harm in healthcare with accountability, with compassion and transparency. And we'll be telling you a little bit more about the work generally, but I would really invite all of you to join in the work with us. We're all nonprofits. We're dedicated to making sure that the best practices, tools, resources are available for everyone to use. But an important part of the work has been the recognition, as you just heard, that partnership with patients, with families, when something has gone poorly, both in terms of responding to their individual event and in terms of engaging patients and families in broader programs for quality improvement and patient safety at the organization, is really essential. It's hard, but it's essential. And that really is at the center of the work that's going on. And it represents really a pretty dramatic paradigm shift. I love our colleagues in risk management. We work very closely with risk managers at our home institutions and nationally. But probably the biggest part of this transformation is the recognition that when something does not go well, the response should really be a part of an extension of the clinical care, the clinical encounter. It's a clinical activity that takes place that has risk and legal implications. It's not a risk management or legal activity that happens to take place in the clinical environment. And nowhere is this more challenging than when something has gone poorly in the birth context. My colleague Leslie Carranza and I have written and done research on this, and she'll talk with you a little bit more about why the obstetric context makes this issue particularly challenging, but we would welcome you to join us and the growing community of organizations that are really committed to doing this well. Well, the next slide, one of the things that we've noticed, and if you can advance the slide, that would be great. One of the things that we've noticed is that a lot of organizations at this point in time are aware of programs like CANDOR. CANDOR is an acronym for Communication and Optimal Resolution. It refers specifically to a toolkit that we and others helped create based at the U.S. Federal Agency for Healthcare Research and Quality, AHRQ. The development and the launch of the CANDOR toolkit was really a game changer in the field, because for a long time, organizations wanted to be more open, transparent, accountable when something had gone wrong, but they didn't know what to do or how to do it. And the CANDOR toolkit was a big help, but we still can see in the field a major struggle with inconsistent implementation, using these principles sometimes, but not others, or using part of the model, but not the whole model for an individual harm event. And so that's why we use the language around highly reliable. We're focused on helping organizations make sure they have processes each and every time to respond and support patients and families when something has not gone well, with transparency, with accountability, and ultimately with learning. Because these programs do have a risk management component, but ultimately they're about high quality, safe, and patient-centered healthcare. Well, the next slide, when I started working in this field 20 plus years ago, people said to me, Tom, I'm not sure this is really such a good idea, because maybe people in healthcare will get the hang of this notion of let's be open when something has gone wrong. Maybe they will get the hang of this very quickly. You'll need to move on to another topic. That was 20 plus years ago, and we just continue to learn. And even today, see how when something goes wrong, we're not always open. We're not always focused on learning. And it's not that we don't want to be open. It's that we get overwhelmed by all of the normal human emotions and reflexes that kick in when you were involved in a problem. I mean, think about a time that you personally have been involved when something has gone wrong, either in your professional career or your personal life. That first instinct is, oh my gosh, do I really have to say anything about this? Maybe if I keep my head down, this will all blow over. Maybe this wasn't that big a deal. Maybe it wasn't really my fault. Maybe if the patient's worried about this, they'll say something. All of those reflexes compound to lead to oftentimes a wall of silence, which it turns out just takes the suffering of patients and families after harm event and makes it so much worse. And there are some unique challenges in the obstetric field. And I'd like to move to the next slide. And Leslie, maybe you can share a little bit about, as an obstetrician, what do you see as the specific challenges to being more open, transparent, and focused on learning when something has gone wrong in the obstetric context? Next slide, please. And Leslie.
Hi, good morning, everyone. It's really truly an honor to be here and speaking to you via Mama's Voices. I just wanted to point that out. I have been following your website for quite a while and very impressed with the work you do. I think one of the most important things for me to mention about myself is I am a full-fledged obstetrician, and I do mostly clinical work, and I try to advance the field kind of on the side. So I am on labor and delivery. I deliver babies. I partner with our midwives, who are amazing. I support my family medicine physicians and our Rochester population and the rest of the health system. So I live and breathe this every day when things don't go well or as expected. If I'm going to assume that based on the audience we have today, that this is not going to sound like earth-shattering information I'm going to share with you, we obviously are all aware that pregnancy and childbirth is really considered by most of our patients a life event instead of a medical episode. I think that when you come in to have your child or you're coming in for prenatal care, it's a very different experience than if you're going to get a hip replacement. People will spend months preparing for the birth of their child. They will set up a nursery. They will have parties to celebrate the birth of their child. So it's a dramatically different experience when our patients are coming into us. And many of them feel that women have been doing this for thousands of years. So what could go wrong? It is just by nature a much more emotionally charged patient and family event. I keep going back to the example that is just a drastically different experience when you are dealing with expanding your family. It is an identity changing event. When you go in to get your gallbladder removed, you're still the same person. When you are coming in to our hospital to deliver, you are no longer the same person. You are now a mother, a father, a birthing parent. You become an aunt, uncle. You become a grandparent. So it's a very unique situation in that part for our patients and their family. And, I think it's important for us to point out that there is a bit of a pressure from society and also internally from the patients to have the perfect birth experience. And when that expectation is not met, what that does to the patient and family. And I think it goes without saying, fear of litigation. I think we sort of pointed that out as something that's very unique. And I'll never forget when I was a medical student at University of Minnesota, when I said I wanted to go into OBGYN, the first thing everybody told me, well, you're going to get sued a lot. Good luck with that. So that just about summarizes what it feels like to be an obstetrician in the current malpractice climate.
Thank you, Leslie. That's great information. So one of our early research studies, 20 plus years ago, when you looked at the literature, most of it sort of focused on, the need to be open with patients and families as kind of a moral obligation. And the hope was if we just told clinicians that you have to do this, it's a part of being a professional, it's an ethical responsibility, that somehow that would be enough. And our research made it very clear that that was not the barrier. Clinicians were deeply committed to the notion of being open with patients and families when something has not gone well, but really struggled to turn this principle into practice. We've talked about how it's human nature to want to keep difficult things to ourselves. When I've, as a clinician, been involved in harm events and been talking with them, with patients and families about them, it is really embarrassing. We're afraid, we're ashamed, we don't know what to say. I got no training in medical school or residency about how to communicate with patients and families when something has gone poorly. At every institution that we've been, and we've supported hundreds of organizations in doing this work, I think frontline clinicians get mixed messages. Even those institutions that are deeply committed to this work, they're mixed messages like, of course, we want you to be open with the patient and family, but don't say that. Or, of course, you can apologize, just don't admit fault. And if you're an anxious clinician, not sure what to say, these mixed messages just really emphasize and lead you to that place of, I think it's best to keep this to myself. And most importantly, many organizations now have the different elements of a communication and resolution program like CANDOR in place, but those different elements are not integrated and hardwired to happen reliably. And that's very hard because it involves not only our colleagues in patient safety, quality, risk, claims, legal, patient relations, our attorneys, it involves all of them working together in an integrated way each and every time, and having some way of knowing, well, how are we doing? Are we responding effectively to these events or not? And the consequences of this on the next slide are pretty substantial. When these processes don't go well, and we have worked very closely with patients and families who have had medical errors and harm events, some of them awful, fatal events, it's obvious that it just makes their suffering so much worse when we can't respond effectively and support them. It makes things worse for clinicians. When I've been involved in harm events, for the most part, I've just put my head down and thought, I guess this is what happens in medicine, and moved on to the next patient. You would not want to be the next patient that I moved on to. It also doesn't make things it's not particularly healthy for the involved clinician. Early on in the work, there was an intense fear that if we were more open, it would lead to an avalanche of lawsuits. The literature is very clear that that is not the case. You can implement a harm response program like a communication and resolution program, and there will not be an avalanche of litigation. In fact, in the aggregate, the chances of being sued and the costs of resolving lawsuits that are filed either stays the same or in some circumstances has gone down with implementing these programs. There's not been a single organization that I'm aware of that has had a worsening overall of their litigation experience. But there's an important caveat here. I said in the aggregate, because if you have a highly reliable harm response program in place, if you're acting in a comprehensive and principled and systematic way when things have not gone well, that means there will be some circumstances where it's the organization that is bringing the event in question to the attention of the patient and family, who might not have had any idea about what happened or had any idea that what happened might have been due to an error. And so will there be cases where you end up paying compensation to a patient and family that under the traditional sort of deny and defend model, you would not have had to pay? Without a doubt, yes. In fact, that's a sign of a highly reliable harm response program. The fact that we reach out and are proactive, even if the patient and family doesn't look like they're going to file a lawsuit, even if it looks like they might not be aware of what happened, happens each and every time. But in the aggregate, those situations where we're offering compensation when the patient and family might not otherwise have filed a lawsuit are far outweighed by situations where the openness, the transparency, the compassion, the accountability, and the learning actually prevent a lawsuit. And we know from an extensive literature that patients and families often sue because they're not getting information. They feel like the organization doesn't care about what happened, isn't focused on learning from what happened and preventing recurrences. And so litigation experiences clearly improve and most definitely don't get worse with these programs. But as I said, these are clinical activities that live within the space of quality improvement, patient safety, and patient-centered and equitable care. So when we don't enact these programs effectively, it's a real lost opportunity for learning. It degrades the institutional culture and climate of safety, and it reduces the public trust in healthcare. The public expects the medical profession will be self-regulating. And I think we really have fallen down on that commitment, and public trust has suffered. And having a highly reliable communication and resolution program is one way of rebuilding public trust. But the current state really is much more like the next slide. The individual in the next slide is at the false apology greeting card aisle, and he's trying to choose between, I'm sorry you feel that way, I'm sorry you got mad, I'm sorry, I'm kidding, just kidding, I'm not sorry, right? This is a silly cartoon. This is not obviously a silly situation when something goes wrong in healthcare. But it just dramatizes how when we aren't effective in our response, it makes things so much worse for patients and families. That's why we're so excited about what we call harm response programs overall, or communication and resolution programs. And on the next slide, we describe the basic features of these. They're comprehensive, principled, and systematic programs to prevent and respond to adverse events. They're best seen as quality and safety rather than a claims reduction strategy. The next slide has the different elements of a communication and resolution program. In the left is the traditional response. The highly reliable response of a communication and resolution program is on the right. And you can see in the rows the different elements of these programs. Early incident reporting is key. You can't respond to problems that you don't know about. Open, ongoing communication with patients and families, really good event analysis and quality improvement, focusing on system solutions and human factors in a just culture context. We're using the term harm and harm event and adverse event intentionally. The early focus of the field was on medical errors, and specifically on harmful medical errors. We've recognized over time that the focus needs to be much broader, not just to situations where there's been an error, but the much broader array of situations where patients and families have experienced harm due to healthcare. And highly reliable harm response programs deal with that entire spectrum, some of which are not associated with an error. In fact, probably 90% of harm events that go through programs like this are not associated with an error. The care was appropriate, or there were errors in the care, but the errors didn't cause the harm event. For all harm events, we want every element of this process to work. There needs to be early event identification, good communication, etc. For a subset of harm events that are due to error or system failure, we should be proactively making not only an offer of financial resolution, but thinking more broadly, what else does this patient and family need? How do we know what they need? We have to ask. Care for the caregivers, an incredibly important part of this work, should be offered immediately. And then patient and family involvement. It should be extensive and ongoing. This should be the most patient and family-centered element of healthcare. When patients and families have experienced harm due to healthcare, I would argue it is the least patient and family centered. And it's not on purpose that that happens. It's that as clinicians, as organizations, we're so wrapped up with what is the effect of this event on us? What is the event of the impact of this event on the organization? that unfortunately the patient and family's needs recede into the background. And that's what these programs try to counteract by making sure the involved patient and family are front and center in the work, both in the response to this individual event, but then also in processes to understand and improve the care of the organization overall. On the next slide, the benefits of a harm response program are really just the inverse of the problems we talked about before. When these programs run well, they preserve trust and meet patient and family expectation. They lower clinician distress, they lower litigation, they promote learning, strengthen the culture, increase public trust. But as I said, the challenge that the field is experiencing and why we're so eager for as many of you to join in this work as possible is on the next slide, and it's the issue of inconsistent implementation. This involves using a comprehensive approach for some cases, but not others, or some but not all elements of the harm response. And it really is fueling the concern of skeptics about whether these programs are patient and family oriented, or whether they're really just sophisticated risk and claims management strategies. And when we have this inconsistent approach, ultimately it means that fewer patients, families, clinicians, and organizations benefit. Well, you heard at the outset and on the next slide, work has been going on in this field for a long time. Early work was done over 20 years ago at the Veterans Administration Hospital in Lexington, Kentucky. Work followed at the University of Michigan, where Rick Boothman and his colleagues really showed that you could be open and make an offer of financial compensation after harm events, and their claims and liability experience got better, not worse. A second wave we would really call a proof of concept. There were several organizations like the University of Illinois, Stanford, a great group in Massachusetts, great group in Oregon, working to extend and demonstrate that these programs could work well in a variety of organizational contexts. And then I've been fortunate to have funding from AHRQ for most of my career. They have been pivotal in this field. It was actually in response to an article in 2006 by then Senators Barack Obama and Hillary Clinton, who wrote in the New England Journal about the importance of rethinking our medical liability system and realigning it with patient safety. 3 years later, that led Barack Obama, when he was president, to announce a new initiative that led to about $30 million in funding from AHRQ as part of their patient safety and medical liability reform demonstration and pilot projects to test and refine these models. Ultimately, that led to the third wave, the CANDOR toolkit. I lead an organization called the Cooperative for Accountability and Improvement. It's a nonprofit program based at the University of Washington, whose sole mission is the spread of highly reliable communication and resolution programs. And about 2 years ago, we launched the Pathway to Accountability, Compassion, and Transparency, or PACT, and we will share a little bit more with you about that in a moment. But I wondered, with the next slide, Leslie, would you be able to share a little bit of your experience piloting some of this in the obstetric context at Mayo? You guys are really doing great work.
Thank you so much, Tom. I just have to say that I've heard you give this talk many times, and every time I always learn something new. It really, truly is fantastic to hear this information again and to be able to share it. I think the presentation hopefully will be available for the participants. I know that was a question. Hopefully we can address that for them. There's so much for us to share about our pilot experience that it was hard to put it in one slide, and I will try to honor that as best as I can, and maybe we can address more things in the Q&A section. I think for us, it became very obvious that a very close partnership with our legal/risk management was an essential step in the development of our project. And Tom's wisdom really helped us in this. We were incredibly fortunate to be able to have Tom come and visit us at Mayo and help us to do an evaluation of where we were at as a department. And our openness and willingness to look insightfully and at our current response to harm events was incredibly helpful. And this is where I would say that having support from key leaders and champions within your institution is really critical to identify them. And I often refer to these early pioneers as the ones that are like really liked by and respected by other colleagues. Having those individuals advocating for why this approach is important is really a key step. And there is, for me, that person was a GYN oncologist that said, this is what we need to do. She used to be the chair of the OBGYN department. And I feel like I need to say her name in this webinar, Jamie Bauckham. She and I met, and she very early on realized this is what we need to do. This is incredibly important for our patients, and having someone that's incredibly well respected within your hospital leadership and community is incredibly important. We can probably talk some more in the Q&A about other really key steps that you need to take if you're going to embark on starting your CRP. What we have learned from our patients is really what I want to showcase, especially because I think this fits really well with the spirit of why Mama's Voices was created and what the audience probably wants to hear, is that what we have learned from our patients is that communication missteps, even ones that seem minor to our team, and we've been calling them micro cuts, these get amplified throughout the prenatal care period and then in their labor and delivery experience and then postpartum and afterwards. And these cause emotional pain and fuel mistrust. And this is even though patients may have received excellent care during their experience with us. And we have found that once you reach a critical threshold of microcuts, that's when the damage is done. And it's really hard to go back and rebuild trust with the patient and family. This is probably not a shocker to this audience and to the Mama's Voices. Nursing communication style has come out over and over as the most comforting to our patients. We have started having reconciliation meetings, as what we're calling them here, when we're reviewing our event findings with the patients and family. And we've had families ask if they could meet with the nurses that were with them at the bedside so they could thank them for the care that they have provided. We have a lot to learn from our nursing colleagues. I think for us, what we're finding out is people like myself as a physician, we tend to have our method of communication is of information. And I think our nursing and I would say our midwives have a very different style of communication that is incredibly important to our patients and is very healing. As an aside, our patients, when we're interviewing them, are pointing us to systems issues that we were not aware of. And if they hadn't mentioned it to us, we couldn't fix them. And they're incredibly astute at educating us on the things that are not working well. From a systems perspective, we have incredibly savvy patients at Mayo. One other issue that I think I'm really excited to see this webinar on holding safe spaces, because we are kind of struggling with this. Our patients are presenting with PTSD signs and symptoms, and we are actually going to be partnering with our perinatal psychiatry group, because our biggest concern is when we are involving patients in this QI work, we do not want to re-traumatize them either. So we are realizing that as much as we are learning so much from the patients, we want to make sure that we sort of follow the do no harm commitment we've made to our patients. So this is something that we are actually actively pursuing. And then last but not least, Tom and I spent a lot of time talking about this, whether it's a bottom to top approach or top down approach to start the program. For us at Mayo, being able to have the concept of CRP and to start doing it was really important for us to do a pilot and see whether this was feasible in our hospital, in our particular division. I think most people would say it was a little crazy to start in obstetrics, because that's, I think, the last place most people think about having a CRP program. But I happen to be an obstetrician, so that's where we went. And we were incredibly fortunate to have the support of institutional quality, legal, and then our own leadership within the OBGYN department who saw the wisdom in this. There's a lot more I could share with you about our pilot experience, and I'm happy to answer questions in the second half of the seminar.
That's great, Leslie. You're doing a great work at Mayo. So just very quickly, let's talk a little bit more about what some of the elements of a highly reliable harm response program are, and then we'll make sure to save plenty of time for questions. So on the next slide, what are the different elements that are required? So a culture of safety, patient support and engagement throughout, clinician support and engagement throughout, event review and action plans, proactive financial and non-financial resolution. Perhaps the best way to visualize this is on what we call the process map, which is on the next slide. We are, as I said, a not-for-profit. We're committed with our colleagues at Ariadne Labs, who are partners in this work, and many of you may be familiar with the great work that Ariadne has been doing around patient safety and the birth experience. We're committed to making sure, excuse me, all of the tools and resources are freely available. We do charge, there's a tuition charge for participating in the learning community, but all of the tools and resources we want to make freely available for everyone to use. This process map is available on the website. We're also happy to send it around afterwards, and we don't have time to go through it in great detail, but you can see at the upper left, a potential harm event happens. For a low harm event, we want clinicians to be ready to use the CRP process and to ask for support as needed. For a higher harm event, we label it a CRP eligible event. This is so important because measures are a critical way of reaching high reliability, and most organizations currently have no idea how many harm events should have gone through their CRP process. And without that, without knowing what the denominator is, you really have no idea how well you're doing. But you can say this is sort of a modified version of a swim lane diagram. Those activities that we talked about, event management, review, clinician engagement, are the rows. The columns are the time frame, early, middle, and late. And you can see how each of these steps links to each other. For organizations that are participating in this work as part of the learning community, they take this map, they make it their own, because the process works a little different in every organization, and then they start to color code. Green, yellow, red. How reliably is this currently happening? Each step. And for most of the organizations, initially, the map is mostly reds and yellows. I would say despite a lot of work in this field for a long time, there are many, many organizations that are highly committed to it. Even those that are highly committed, I've not been to one that has said, oh yeah, we've got this pretty much nailed. This works every single time and it works well. We're all as a community trying to learn how to do this better and to do it with more reliability. So happy to share a copy of the process map. The foundations of having an effective program are on the next slide. Leslie talked about many of them. Leadership, engagement, and commitment is key. We can send around a paper, an editorial we published 2 years ago about making communication and resolution programs mission critical. They can't just be important or very important. It has to be on the top list of priorities of the C-suite at the organization. A second element of that paper was the critical role that patient and family engagement plays in having an effective communication and resolution program. Not all organizations are ready for this work, and it's best not to start until you are ready, and there's a readiness assessment document that you can use. I've talked several times about metrics. They really are an important way of understanding how well are we doing. And then there needs to be a willingness to really hardwire these program elements into organizational workflows so that it doesn't feel like it's really add-on. So I've mentioned a couple of times on the next slide, the pathway to accountability, compassion, and transparency. Our patient and family advocates came up with that name, which is great. And for those of you who are interested, would love to have you participate. There are a variety of ways to do that. Our mission for the PACT Collaborative is on the next slide. It's to inspire and guide healthcare organizations in the implementation of highly reliable harm response programs through collaborative learning, robust tools and resources, innovation, and the spread of best practices. There are 3 levels of which you can engage with PACT. And on the next slide, we just wrapped up the first round of the PACT Collaborative. That's in the middle of the picture here. We had 19 organizations bring close to 40 hospitals for a 15-month IHI Breakthrough Style Series Learning Collaborative. We're recruiting for the next round of the PACT Collaborative now. We've got a great cohort already, but we would welcome some more. So please, if you have any interest, let us know. The graduates of the collaborative have joined what we call the PACT Leadership and Innovation Network. That's a longitudinal program that's meant to support organizations that already have a strong harm response program in place. And for those who are interested in sort of dipping their toes in the waters, there's the PACT Community of Practice. Just a little bit more about the collaborative. For those of you who are interested, it's a series of virtual learning sessions with action periods in between those, and then individualized learning and coaching. Each organization develops a personalized aim statement to figure out where they want to focus their work. There's a 200-page change package with new tools, resources, and metrics. The part of the first round of the collaborative that people really loved the most was the learning from each other. As I've said, as you've heard from Leslie, this is very hard work. And learning from your colleagues, it's really an all teach, all learn sort of approach. Where there's so much to be gained by hearing from how other organizations are doing things, and for organizations that are doing an element of this really well and sharing that with their peers. And then there's specialized content and breakout sessions. And if there were a cohort of organizations that were really interested in the obstetrical issues, happy to form a little cohort within the collaborative. And you can learn more about PACT at the website down on the address there. So with that, we'd love to hear your questions. As I said, when things go wrong in healthcare, especially in obstetrics, it should be the most patient-centered thing that we do, how we respond. Unfortunately, our reflexes as humans, the lack of tools and resources at the organizational level oftentimes get in the way, and it makes the suffering of patients and families so much worse. There are a whole host of tools and resources now available to help organizations develop highly reliable harm response programs. And I would welcome all of you to join the growing community of patients and families, healthcare organizations, insurers, clinicians, and other stakeholders who are really committed to working together to turn this vision into a reality. So with that, I'll pause, and we'd love to hear any questions that folks have.
Well, Drs. Gallagher and Carranza, I'm just on behalf of all the participants here, thank you so much. This is really inspiring, and I think paves, it's the light at the end of a tunnel of things that that can be done. Let me share my video here real quick. So we have gotten a couple questions in chat, and I would encourage everybody watching to go ahead and use chat. We've got quite a few participants. It might be a little easier than trying to do it via video. Throw your questions into chat, and I'll just start off by asking this. Is this an all or nothing proposition? For folks who want to step foot into this space, do they need to fully embrace the entire PACT program in order to, quote, do it right? or not do it at all? Or are there some initial baby steps that people can take to start grooming a culture for this kind of work?
There are some baby steps, although the organizations that have had the most success are the ones that have done this comprehensively. The good news is that many organizations already have all of the different elements present to some extent. Part of the issue is hardwiring those different elements to work together more effectively, and being more systematic about things. So it's not necessarily an enormous amount of new work. It's a way of restructuring and doing the work differently. Without senior leadership engagement, it's very difficult to move this work forward. And so the C-suite, department chairs, risk, legal, all need to sort of be on board with this. But if you wanted to start, one area is really thinking about, well, I would point towards two of them. One is, what are your programs like right now for communicating with patients and families when something has gone wrong? There are all sorts of new tools and resources, and we're happy to share them with you to support clinicians in having more effective conversations with patients and families when something has not gone well. We're aiming for an open, supportive, empathic process, but one that's highly disciplined. The biggest mistake we see in this area is a lack of planning and preparation. I would underline and put 5 exclamation points by what Leslie said about how our nursing colleagues, and this is will be physicians may be unhappy with me, but I will say overall, our nursing colleagues are more skillful, especially at the emotion handling part of these very difficult conversations. It's better integrated into the nursing curriculum, into the nursing culture, and the nurses are at the bedside day in, day out, all the time. And so they naturally tend to be much more gifted communicators with patients and families than their physician colleagues are. That's why we really encourage organizations to have clinicians have these conversations as teams.
Yep.
A doctor-nurse dyad, especially a little bit more experienced nurse. Sometimes the new nursing graduates are just sort of trying to get their feet underneath them. But that's one area. Can we improve the way we communicate with patients and families? And then care for the caregiver is huge.
I wonder if we could pop over to Dr. Carranza to just before you get off the nursing topic, because one of the questions was about nursing staff, and I'd love to hear if you could talk about that through the lens of the OB environment that you're living and working in. How do you help organizations, how would you recommend organizations tie nursing staff into this process? We know that particularly coming out of the pandemic, that nursing turnover has been extremely high, and they're often caught in the middle of providers and patients. So what advice might you have specifically for nurses, Leslie?
Well, first of all, I have to say, I am channeling my nurse administrator and my nurse managers right now, because they've educated a lot of us in terms of the nursing role for CRP. I think one of the things we picked up very early on is when we were doing our communication trainings in the simulation center, which Tom helped put together for us. Doing those conversations as a dyad was incredibly powerful. And I cannot tell you how many times the clinician was going down a deep hole and was really not saying the right things. And the nurse would gently go, I think what my colleague is trying to say is this. And it was incredibly powerful. So we have partnered with our nursing leadership and have recognized their incredible role in helping having these conversations at the bedside. We've created now materials for training for our nurses when we're going to ask a patient if they're interested in joining our CRP programs. Our nurses are fully on board because they understand how important this is. They start talking to the patients and saying, this would be a great program for you. Here is a pad and a piece of paper. Start writing down your questions. The team is coming to talk to you. When would it be okay for them to come in? When would you feel ready? I think that engagement with nursing from the very beginning, when we went and audited the PAC Collaborative, the first people that I grabbed to come with me was one of our nurse managers, and that was key to have them on board for this. I don't think I could have done this journey without their support, because many times they were the first ones saying, this is really important, we need to do this.
Sure. And I wonder if either one of you could comment on one of the other questions that is focused on what evidence is there or experiences have you all had with working this process in environments that have a high percentage of BIPOC patients or impoverished communities, federally qualified health centers, other places where you're dealing with a very special population. Does this work in those settings? Do we have experience of how this process changed the culture in those kinds of organizations?
This can work well with a variety of populations. And I see, I believe Tracy Deskin from UW might have been on earlier if she's not still on. Tracy is an amazing risk manager at Harborview, and then Liz Augusta, who's a senior risk manager at LA County, which has a high proportion of BIPOC patients and works with a wide variety of populations. These programs can work well. Additional work is required around trust building, because many patients from historically marginalized groups come to the healthcare encounter with lower levels of trust, and that needs to be taken into account. Many of these organizations are lower resourced, just financially, and so you need to think carefully about what are the practical realities of making this work well. But there are several folks on the webinar with a deep experience, and Liz may be sticking your email in the chat, or Tracy. They're great resources. I do think that there's more work that needs to be done to adapt the content. Much of this has been developed in more highly resourced areas and adapting it for lower resourced areas. We have a large several $million grant from AHRQ looking at delayed cancer diagnosis among BIPOC patients and other vulnerable populations, and how do we support them. So more is being learned there as well. So there's a great community working on this topic, and would love more folks helping to push the ball forward.
Thank you for that. There's another question that's asking about risk managers. You certainly made the point in your talk that they are part of this process. Do they need to come to the table right away? Are they like, what role do they need to play in this process, given the fact that you're trying to make this paradigm shift away from this really being a litigation mitigation strategy and more of a patient safety and quality improvement strategy?
The risk managers are critical partners in this process, and they need to be partners from the beginning. They have incredible expertise in responding to harm, but the big difference really is, what are the goals? The goals of a highly reliable harm response program are to help patients and families understand what happened to them, support them, drive learning. All of the entities involved in quality and safety in an organization have to come together around that goal. If the risk managers aren't involved, the process doesn't go as smoothly. So it really is just a focus on the goal, and then using the expertise of everyone who's involved to drive the process forward.
Yeah, and what I can add, I'm so sorry about that. What I was going to say is that having risk managers that actually tell our obstetricians, this is okay for us to do this. It is part of our mission. It is something that is incredibly important for our patients, and this is the right thing to do. Hearing it from a risk manager, it's incredibly important for the obstetrician, because oftentimes we are scared of what we can or cannot say.
Absolutely. So we're out of time now, but I did want to just personally share that I think one of the major paradigm shifts in this field is this idea of transitioning from this being around errors and being rather focused on harms. because error implies that someone did something wrong. And we all know that while that might be the case, more often than not, it is there's a larger system issue at play. And we're not going to work on improvement, quality improvement, if we're focused on blaming. So I know certainly in the obstetrics field, a lot can go wrong. I mean, you laid out the situation beautifully at the beginning, where pregnancy and childbirth has become this, seeking to attain the perfect experience, which rarely happens. And so what we're really trying to do is address harm to the patient and involving her family as well. So with that, we are out of time. We're going to just transition to our next slide that has contact information, which I want to thank everybody who's presented, and those of you who are watching, feel free to grab this information. And then we are going to take 1 minute to ask for a very critical component to this, which is our brief evaluation poll. So if you could go to the next slide. And oh, I thought we were going to have a poll. Okay. Sarah, I don't know if you have a poll that you're going to be pulling up. If not, we'll just leave it here at the contact information. Thank you very much to our presenters. This has been really inspiring, and clearly there is a lot more information and immense resources available at the websites that you shared. We look forward to continuing the conversation. And again, don't forget, we've got 2 more webinars coming up that we hope will be super useful to you all. Thanks, everybody. Have a lovely day.
Bye-bye.